Hi, and welcome to Fairview Range Focus. My name is David Hall. I'm one of the Vice Presidents with Fairview Range, and I'm happy to welcome you here today. Today we're going to talk about colorectal cancer. We try to each month talk about health-related topics, and so March is Colorectal Cancer Awareness Month, and so we have the pleasure of visiting with one of our general surgeons, Dr. Laura Stoiber, and she is a general surgeon at Fairview Range, and who knows a lot about colorectal cancer and its treatment and care. So I'm looking forward to our conversation, and I've got some questions, and I hope to better understand what this is, for one, as well as just better understand colorectal cancer. So I hope you'll enjoy it as well. So welcome, Dr. Stoiber.
Thank you. It's good to be here.
So maybe we could start real basic and just maybe tell us about what colorectal cancer is.
Colorectal cancer is cancer that develops in the colon or the rectum. Sometimes these cancers are referred to separately or either colon or rectal cancer, depending on where they start. They have many features in common, which is why we usually discuss them together.
Okay. So you said it was cancer of the colon or the rectum, and is that something that is more typical in men or women, or is there any gender difference in that regard?
Colorectal cancer is the third most common cancer in the United States, and generally it affects men and women equally. There is no gender difference with colorectal cancer death in the United States.
Third most common. Wow. Okay, so it's pretty prevalent then.
Very common.
And affects both men and women.
Equally.
Okay. So how does the cancer, I know it's something that takes a long time to develop, as I understand. How does it begin? Is there something that starts it, or?
Generally, colon cancer is very, very slow growing.
Okay.
It takes, generally, colon cancer starts as polyps, and of course there's always, outliers out there. Polyps are an abnormal growth of the lining of the colon. It takes years for a polyp to form, and then it takes years for a polyp to turn into cancer. And if we can get those polyps out before they turn into cancer, we're preventing cancer before it even starts.
Okay. So the whole idea is to get the polyps removed, and when you remove them, are they at a benign state, or they're not a cancerous at that point? Okay.
Correct. They're usually a benign. They're what we call a precancerous lesion. They're not a cancer yet. So if we can get them out, we're preventing cancer before it can even start.
Okay. All right. So what about tests for colorectal cancer? Are there tests that you can do?
There's many different tests that you can do. And I always tell my patients the most important test is the one that you will do.
Makes sense.
People who generally have no risk factors for colon cancer and are what we term average screening, we recommend you start testing for colon cancer at age 50. And like I said, there's many different things that you can do to test, and it's important that you discuss them with your primary physician and decide what you need to do or what you want to do to get tested. But generally, what we are talking about when we were talking about cancer screening, we're talking about testing the stool for blood and doing some type of imaging of the colon and the rectum with either a scope, CAT scan, or a barium enema.
Okay. So different procedures, would you choose a different procedure based on the individual, or is it more their preference, or is it based on the clinically speaking?
All three.
All three, okay.
All three.
Okay. Okay. How about risk factors? Is there specific risk factors that you can tell us about that are associated with colon cancer?
Yes, there are many different risk factors. Obviously, some of them we can control and some of them we can't control. Certainly our family history makes a very big difference. There are many types of inherited cancer syndromes that run in people's families. If you've had colon cancer in the family, if anyone in your family has had polyps before, people with inflammatory bowel disease like Crohn's or ulcerative colitis have a much higher risk of developing colon cancer. African Americans have the highest incidence of colorectal cancer, and this, I don't think we quite understand for sure why this is. Jews of Eastern European descent also have a very high risk for colorectal cancer. And some of the things we can control, people with type 2 diabetes also have an increased risk for colorectal cancer and unfortunately have a less favorable prognosis after they've been diagnosed. Obesity, physical inactivity, high-fat diets, heavy alcohol use, and smoking.
So now I've heard some people say that in relation to smoking, that you're taking the smoke into your lungs, and that they find that odd that would affect your colon, considering that. How does that occur? I mean,
when you smoke, 18% of the smoke goes into your GI system.
Okay.
And it can cause changes in your DNA, in your genetic makeup.
Okay.
So it doesn't all go into your lungs.
Makes sense. So is that also true then for those that chew tobacco, the smokeless tobaccos?
Yes, absolutely.
Okay. All right. Interesting. All right. Well, let's talk a little bit about the treatment, if we can. And so you have a very interesting device here, and I'm hoping you could tell us about it. And as I understand, this is one of your tools that
Yes.
you utilize for diagnosing or treating. Maybe you could tell us about that.
Okay. Well, one of the things that the American College of Surgeons and the American Cancer Society recommend is they recommend for people of average risk is they have a routine screening colonoscopy, at least minimum of once during their lifetime, and preferably start somewhere around age 50. And that's just for routine cancer prevention.
Okay.
So what I brought with me today is our colonoscope.
Colonoscope. Okay.
And this is what we use to do a colonoscopy. And this is how we find polyps. And again, if we find polyps during the colonoscopy, even I can't say it, we go ahead and take the polyps out, and we're preventing cancer before it can even start.
Okay. So I have to ask, so you say you take the polyp out, but that just looks like a tube. I mean, how do you actually remove the polyp with that?
There is actually, and I don't know if you can see, there's a channel, and we put a thin flexible wire that goes down.
I see.
And it comes right out the end of the channel.
Okay.
And it has a loop on it. Looks just like a lasso, and we hook that up to an energy source.
Okay.
And we actually burn them out.
Okay.
And then we pull it through, and we have the polyp.
I see. So you can do a lot with that scope. It's not just for looking through to see something, but you can actually remove things. And,
Yep.
Okay.
We can remove polyps. We can take biopsies. You know, if someone had a bleeding ulcer, we can stop bleeding with it as well.
Okay.
It's a very useful tool.
So what's necessary? I mean, as far as, I mean, it looks a little scary. It looks a little intimidating. So what do you want to do in order to have this procedure done? Is it like, do you have to stay in a hospital for several days? Or?
No. It's a very simple procedure. You come in as an outpatient, have the procedure done, go home the same day. The worst part about the whole procedure is you do have to do a bowel prep the night before. And I think that's what people dislike the most. Unfortunately, you have to be completely cleaned out, otherwise I can't see anything.
Sure.
And we do make you drink the medication that flushes your system out.
Okay.
And then when you come into the hospital the next day, we do start an IV on you, and we do give sedation. And the medications that we are giving now, everyone just sleeps right through it. You won't feel anything, and you won't remember anything.
I'm counting on that.
But you do need to have somebody to drive you home afterwards.
Okay.
But our sedation policy is very nice. People don't remember having anything done.
Okay. And so after the procedure's done, you heard you say someone drives you home, but you can go home right away afterwards? Yep. You don't have, there's no overnight? Or?
No,
okay.
No. You're in recovery for about 30 minutes to wake up, and we make sure that you can eat something, have a little juice, a few cookies, and then you're able to go home.
Okay.
And we tell people just to take it easy for the rest of the day, but by the next day you can go about all your regular activities.
Okay. So is this something that after you go home, it takes a while to recover, or can you go back to work right away the next day? Or?
Yep, you can go back to work right away the next day.
Okay.
Most people have few, if any, side effects from having the scope done.
Mm-hmm.
The worst may be you may be a little gassy.
Okay.
But otherwise, no.
Okay. What about eating afterwards? I've heard you say you don't have to clean out your intestines and bowels before the procedure, so after it's been done, I'm thinking you might be really hungry afterwards.
Most people are pretty hungry.
Okay.
And, but I usually tell people just to start with kind of a bland, mild diet. Go home and have some chicken soup. I wouldn't stop off and have a steak or go out to lunch, but I would just kind of have something bland and simple.
Okay.
But as far as there really aren't any real heavy restrictions afterwards.
Okay.
Just moderation.
Okay. All right. Well, that doesn't sound too bad at all. So why is it that, do you think, in your opinion, men seem to have a real fear? Being one, I can kind of understand that. But is there, it sounds like a procedure that is relatively easy. You don't really remember anything about it. You get to go back to work. Why is there such an aversion to it, do you think?
It's just gotten a bad rap in the media, so to say, and I think there's a certain stigma associated with it. But really, most people get through it, and they're like, oh, well, that's not as bad as I thought it was going to be.
Yeah.
Because it's really not that bad. The bowel prep is the worst part of it, and after you completed that, the rest of it's easy.
Okay. Okay. So if an individual maybe who's listening today might hear about this and say, I really should do this, do they need to see their family practice physician or family provider first before they would come to see someone like you, or?
We do need to have a referral done,
okay,
preferably. But if you don't have a family physician, I think you could just call the office and get an appointment to see one of the surgeons in town.
Okay.
There's 3 of us in town. We all do colonoscopy.
Okay.
And we see you in the office, do a consult, and we would get everything set up.
Okay. Well, it's great that it can be done here locally, and someone doesn't have to leave town to have that done, sounds like. So that's
absolutely not.
That's a great thing. I would assume that there's a risk in not having it done. If an individual felt like, I just don't want to do it for whatever reason, that there's a risk associated with that as well. And you've talked about some of those risk factors and everything. But so what happens if maybe an individual does develop colon cancer, didn't have any screening done or whatnot? Can that be a life-threatening disease?
Certainly can.
Okay.
Like we talked about before, colon cancer is the number 3 cause of all cancer deaths in the United States.
Okay.
And there's been a big push in the U.S. because colorectal cancer is so preventable. But we don't do the greatest job about getting people in and getting them screened. I think less than 50% of all U.S. adults have a colonoscopy ever. If someone is diagnosed with colon cancer, again, it depends on what stage the cancer is diagnosed at, but generally surgery is considered the mainstay treatment. And certainly radiation and chemotherapy also play a big part of that as well.
And much of that sounds like, for the most part, could have been prevented had the individual maybe had screening early enough? Okay.
Certainly we don't know enough about cancer to prevent all cancers, but they estimate that a large portion of those are preventable cancer deaths.
Wow, that's a good lesson, and I guess I would hope that if you're listening today and you're hearing that, that'll something you can really hang on to. The screening can really prevent most of the colon cancers that individuals might develop. So, well, great. Anything else that you'd like to add or share in regards to colorectal? Or
I would just really encourage everyone at some point during your lifetime, and again, it's a personal decision. You need to discuss it with your primary care physician, but you do need to do something to get screened.
Okay.
I certainly urge everyone to get a colonoscopy at some point during their lifetime. Like I said, we've all heard the horror stories in the media, but it's really not as bad as everyone makes it out to be.
Good.
It really isn't. And I would really encourage people to do, if you just can't go get a colonoscopy, talk to your physician or your healthcare provider and do something for cancer screening, because it is very preventable.
All right, very good. Well, thank you, Dr. Stoiber. And that'll wrap things up for us today. We really appreciate your visiting with us and hearing more about colorectal cancer. And again, March is if I say it right, Colorectal Cancer Awareness Month.
Yep.
Did I get that right? Okay. Well, thank you again, and thanks for listening. I hope you'll watch next month for another show of Fairview Range Focus. And for more information on our services, we'd encourage you to look up our Fairview Range website at www.range.fairview.org. So watch next month for another segment of Fairview Range Focus, and thanks for listening.